All right, so we'll get started here. Again, welcome to today's IAS USA webinar. Today is Tuesday, June 28th, 2022. My name is Jose Francisco, and I am a project manager at the IAS USA. And we are excited to cover today's presentation regarding the implementation of long-acting PrEP in a case-based panel discussion and presentation. We are delighted to welcome today's moderator, Dr. Jose Castillo-Mancilla, Associate Professor of Medicine at the University of Colorado, who will be going over the introduction slides and will be providing a presentation as well as moderating the question and answer at the end of each presentation and the panel discussion at the end of this webinar. I'd now like to welcome Dr. Castillo, who will be going over the intro.
Good afternoon, good morning, everybody. Thank you, Jose, for the introduction, and thank you, everybody, for coming today. As Jose mentioned, I'm Jose Castillo-Mancilla from the University of Colorado. I think we are in today for a real treat with a great panel of experts today to talk about implementation of long-acting PrEP. I will start with a couple of just our outline for today. I will present some of the phase 3 data to set the background and the stage for the panel. Then Dr. Hyman Scott will talk about clinical considerations and implementation of long-acting injectable PrEP. This will be followed by specific complicated patient case scenarios by Dr. Kimberly Scarsi with some focus on pharmacology. And then Dr. Colleen Kelley will close us up today with talking about diagnostic dilemmas and treatment dilemmas in persons who receive long-acting injectable PrEP. And then at the end, we'll have a discussion, Q&A after each presentation, but also at the end of the panel. These are the financial relationships of the board members of IAS USA that assist with content on the web board. And these are the financial relationships of me as a speaker and the presenters today. Just to bring this up, and as a few housekeeping items, IAS USA has determined that this designates this as a lab activity that qualifies for 1.5 AMA and PRA Category 1 credits. And physicians should claim only the credit that is commensurate with the time they participate in the activity. This is also approved for 1.5 credits for American Board of Internal Medicine maintenance of certification, and also for nursing, pharmacy, and pharmacotherapy credits. And the instructions on how to claim those credits are listed, will be listed at the IAS USA website, as you can see below. We want to thank our supporters for making this activity possible. Here are our supporters that are listed. So thank you for their contributions. And just as a reminder, the on-demand recording and slides from this webinar will be available within 24 hours after the live broadcast. So within 24 hours of today at the IAS USA website as well. In terms of how to navigate the activity, I think it's important that we just take a minute to discuss this. You will see poll questions that will be appearing in a window. The window will show the poll questions. Then you'll choose your response, and then the responses will be displayed after the poll closes, usually about 30 to 40 seconds to time to answer the question. You can also, this is very important, we ask that you submit your questions using the Q&A button. And this is very important because this is the specific area of the that we will be evaluating and moderate, that I will be looking at for questions. We have received a lot of questions already in the pre-registration activity, and I'm sure we'll get more. So we apologize in advance if we're not able to address all the questions during the time allotted. The chat will be open for discussions and other comments, but again, please do not submit questions in the chat because we won't be able to monitor those. We only monitor them in the Q&A. These are learning objectives today. We're going to talk about the data and the key points that support the use of long-acting injectable CAB as PrEP, talk about the challenges of implementing it in the clinic, talk a little bit about monitor drug-drug interactions and how to manage it in the setting of pregnancy. And we'll talk about the difficulties that we will face and are facing now, interpreting diagnostic tests, and then how to treat persons who have had previous exposure to CAB and acquired HIV. And with that, I'll start by setting the background and talking about the phase 3 data that led to the approval of long-acting CAB PrEP. A word about long-acting cabotegravir. As you know, it's an integrase inhibitor that is used for prevention and treatment. It's approved for both. for treatment is used in combination with long-acting rilpivirine. It's a very potent integrase inhibitor. The dose of cabotegravir is injectable is 400 milligrams or 600 milligrams. They're both injected intramuscularly in the gluteus. The 400 milligram dose is injected every 4 weeks, and the 600 milligram dose is injected every 8 weeks for treatment along with rilpivirine. Cabotegravir is metabolized by the UGT pathway, and it does not really appear to inhibit the cytochrome system. It's a substrate of several transporters, including PGP and BCRP. And renal impairment and hepatic impairment can increase the free concentrations of cabotegravir in plasma up to 30 to 60% for both of these chronic conditions. Although currently no dose adjustment is necessary or recommended for advanced renal disease, however, it's recommended to monitor for adverse events. And for hepatic impairment, we know that mild or moderate hepatic impairment does not require dose adjustment, but we really don't know much about advanced liver disease. Cabotegravir is highly bound to proteins, over 99%. And as a long-acting medication, as expected, it has a long pharmacokinetic tail with measurable concentrations in plasma for a long time after an injection. And some studies have shown that up to 76 weeks. And it also has wide pharmacokinetic variability, and is influenced by multiple characteristics on our patients. But some of the two that are main ones that drive the variability are gender and BMI. And this was recently evidenced in data on a pharmacokinetic model that used over 23,000 plasma concentrations derived from over 1,600 persons with and without HIV that were participants that were enrolled in the phase 2 and phase 3 studies. And during this pharmacokinetic model, through this, it was determined that after an injection, IM injection, the absorption in females can be 51% lower compared to males. And also absorption can be 20 or almost 30% lower in participants who are in the highest BMI decile, over the 90th percentile, compared to those in the lower 10 percentile. We also know that longer needles increase the absorption rate. And again, these are factors that interfere and drive the variability that we have observed in drug concentrations. Why do we need long-acting PrEP? We know that daily PrEP is highly effective in men and women against HIV acquisition when adherence is high. But obviously this requires exactly that. This requires high adherence, not only at the time for us, during the time of exposure, but also high persistence on the high adherence and durability of PrEP. And this remains a challenge for some persons that are at risk for HIV, who face adherence barriers for a multitude of reasons. So options that do not require daily dosing and do not require planned dosing are attractive options for some patients and persons at risk. And of course, this is where long-acting PrEP may fill this gap. So this led, the potential benefits of long-acting CAB as PrEP led to the development or to the completion of 2 landmark phase 3 studies that evaluated the efficacy in the diverse populations. The first one is both of the studies were performed through the HIV Prevention Trials Network. The first one is HPTN-083, which is mentioned on the top of the slide, and then the other one is HPTN-084, and we'll talk about them in a second. We'll start with HPTN-083. This is a double-blind, double-dummy, randomized, placebo-controlled trial that compared the efficacy and safety of this strategy, long-acting CAB for PrEP, in cisgender men who have sex with men and transgender women in 7 different countries around the world that are listed there at the bottom. At the design of the study, it had 3 phases. The first phase was the oral induction of to assess for tolerability of cabotegravir prior to the injections, and included, as you can see in the top of the top bar there, induction with oral cabotegravir 30 milligrams once a day, in addition to oral TDF-FTC placebo. And the comparator arm included oral TDF-FTC daily versus oral CAB placebo. These participants were randomized to one of these 2 arms, in a 1-to-1 fashion. After the induction period, participants who were randomized to the CAB injectable arm received 600 milligrams of injectable cabotegravir every 8 weeks, plus daily oral TDF-FTC placebo. And those randomized to the oral TDF-FTC arm received daily oral PrEP, TDF-based PrEP, plus cabotegravir placebo injected intramuscularly every 8 weeks. The study follow-up was for 153 weeks. And at the end of the injection phase, participants who were then provided daily oral PrEP with TDF-FTC to cover them during the long pharmacokinetic tail that I mentioned earlier in my presentation after the last injection with cabotegravir. The population that HPTN enrolled was diverse. You can see that the study enrolled over 4,500 participants. About 87% were cisgender men who have sex with men, and about 13% were transgender women who have sex with men. You can see the population, 2/3 of the population were young, under 30 years old, and 43% came from Latin America, 37% from the United States. The median age of the population was 26 years, and 50% of the participants enrolled in the US were Black or African American. Here are the results of HPTN-083. You can see that there were a total of 58 incident HIV infections during the study, 42 in the oral TDF-FTC arm, and 16 in the cabotegravir injectable arm. This corresponded to a hazard ratio of 0.34 for the cabotegravir arm, so less than 1, which means it's protective, with a highly significant p-value there. And this translated to a 66% reduction in incident HIV infections in the long-acting cab arm compared to the TDF-FTC. So very, quite a strong effect there of superiority. And like with any integrase inhibitors, weight was a variable that was evaluated throughout the study. Similar weight changes were observed in both arms, about 1 kilogram per year in both groups. There was initially a little bit of more weight gain in the cab arm that was relative to a decrease in weight on the TDF-FTC arm, but in the end, weight gain was similar for both groups. And of the 16 infections that occurred in the cabotegravir arm, 3 occurred during the oral lead-in period, so in the phase 1 of the study, but 4 infections occurred in the injection phase in participants who had on-time cabotegravir injections, so adequate CAP-LA dosing, and also they have expected drug concentrations, so they were considered through breakthrough infections. When they the investigators looked at subgroup analysis to look at the efficacy, they corroborated that the magnitude and the direction of the effect was similar across multiple different subgroups, especially those in whom oral PrEP intake has been low, like those who are younger than 30 years of age, participants who were reported were Black, and also transgender women. So it was reassuring to see that the effects were similar across all subgroups. The other study parallel was HPTN-084. The study design was very similar than 083, also with an oral lead-in of oral cabotegravir plus TDF-FTC placebo, or vice versa. And then the injection was also, the injection phase, it also included 600 milligrams of cabotegravir every 8 weeks, plus TDF-FTC placebo, or vice versa. And it was also followed by an open label daily TDF-FTC 48-week observation in the tail phase, if you will. And the duration of follow-up was a little bit longer, and this study was conducted in cisgender women in 7 countries in Africa, and the countries are listed there at the bottom of the slide. The population characteristics are shown here. The study enrolled a little bit over 3,200 cisgender women, and you can see the distribution of age. About half were younger than 25 years of age, and about a third had a BMI greater than 30 kilograms per meter squared. The frequency of both chlamydia and gonorrhea were similar, these STIs were similar in both groups, and about 41 participants on the study came from South Africa. Interesting to note that the HIV incidence that was observed in the study was 1 case per 100 person years, which was considerably lower than the 3 to 4 cases per 100 person years that have seen in previous prevention studies. Here are the results for HPTN-084. You can see here that there were 40 incident HIV infections in the study, 36 in the TDF-FTC arm, you can see that in red, and 4 in the cabotegravir arm in blue. This corresponded to a hazard ratio of 0.12 for the cabotegravir arm, so less than 1, meaning it's protective, also highly significant, and translated into an 88% lower risk of acquisition of HIV infection in the long-acting cabotegravir arm versus daily oral TDF-FTC. So again, also very even higher protective effect than HPTN-083. Weight gain was similar for both arms, also a little bit of a drop initially for the TDF-FTC arm, but in the end, similar for both. And of the 4 infections in the cabotegravir arm, 1 of them occurred in the long-acting arm injection phase, but had late infections, and there was an issue there with adherence for this participant. In terms of safety, and you can see there that the grade 3 adverse events for OA3 were very similar, 33% for both groups, and serious adverse events, 5% were also balanced between both groups, and only about 2% of participants discontinued long-acting CAB injections due to an adverse event, which most frequently was an injection site reaction. For OA3, grade 3 events, adverse events were lower in proportion in general, but also similar between both groups, about 17%. About 2% had serious adverse events, and there were no differences per arm. And there were no discontinuations in this study due to injection site reactions. And pregnancy rate did not differ by study group. So the efficacy and safety that was observed in these 2 landmark studies, phase 3 studies, led to the approval of long-acting CAB for HIV prevention by the FDA just recently in December of 2021, approved for adults and adolescents that are at least 35 kilograms of weight. And the dose, as mentioned, is 600 milligram gluteal injection, with the first 2 injections 1 month apart, and they're every 8 weeks thereafter. And the FDA actually made the oral lead-in optional and can be skipped per discussion, through discussion with clinician and patient. These are the phase 3 data. I think sets the stage for our next presentation. I will stop here, and Dr. Hannah Scott will take over. And just as a reminder, we'll have time for questions and answers at the end of each presenters, and then at the end for the panel.
Great, thank you, Jose. So I am going to talk a little bit about clinical considerations and implementation of long-acting injectable cabotegravir. Jose, are my slides showing up okay?
Yes.
Yes, we see them.
Great. So we're going to start with some cases. So this is the first case, 29-year-old MSM who's in a different relationship with a positive partner for the last 2 years. His partner is only occasionally virally suppressed, so your patient will access PrEP. He has other sexual partners and reports that he uses meth almost daily. And he reports okay adherence to his medications for depression. And when you explore what okay means, he states that it's about 1 to 2 days a week. So what PrEP options would you offer him? So daily oral TDF-FTC, daily oral TAF-FTC, on-demand PrEP with TDF-FTC, or long-acting CAB with an oral lead-in, or long-acting CAB without an oral lead-in. Great. So about 60% of folks said that they would do CAB with an oral, without an oral lead-in, 25 without an oral, with an oral lead-in, and less than 10% would do any of the oral options. Colleen, I don't know if you have any thoughts on how you would approach this patient's choice in PrEP options.
So I don't think I would choose one for the patient. I think I would discuss all of the options available and work together with the patient to figure out which modality is most desirable for them. And I think we know that when the patient chooses the modality that's most desirable to them, they will adhere to that the best. And so that's the way I think I would approach it. Although obviously I think there are some red flags for adherence challenges in this particular case scenario. We just need to be mindful of that and work with the patient through those.
Yeah, that's spot on, and that's exactly how I think I would approach it as well. And so these are some of the CDC guidance on PrEP from the 2021 update, and essentially says that all sexually active adults should have PrEP discussed as an option. And there are many options. So this is a cisgender man who has sex with men. So there are essentially four different PrEP options that are available. So using a shared decision-making approach, helping the patient decide which one works best for them. Because I think, to Colleen's point, the best PrEP is the one that somebody will actually use. And so counseling them on using motivational interviewing and sort of reassessment as well, if somebody decides on a PrEP option, that they have the option to change later. I did want to highlight some of the challenges with the oral lead-in. So the oral lead-in in the studies was really around safety and ensuring that that providing this medication in the setting of a clinical trial, if it was associated with safety, it cannot be dialyzed. And so if somebody did have a complication, it would be difficult to remove the drug. The safety data show that there was no safety signal for this agent. And as Jose mentioned, there were HIV seroconversions that occurred during the oral lead-in. And so I think the point of, if somebody's having difficulty with an oral medication, giving them an oral medication, if that's not what they desire, can be problematic. And in 083, people had the option in the open label extension to choose to transition from the active Truvada arm to cabotegravir with or without an oral lead-in, and 70% of people decided to go direct to inject, primarily driven by, I think, the discussions around safety that came out from the study. And we don't want to just forget about these great options that we have for oral PrEP for those for whom this is beneficial and desirable. There are a lot of options for oral PrEP, including the flexibility for implementation, options for on-demand dosing for some populations, the reduced burden of HIV testing, and of course, cost for the generic TDF-FTC options. It is daily adherence, so for those that is problematic, and the 211 regimen is often more complex. And stigma associated with having pills around is not always acceptable for all populations. And we've seen this particular challenge among cisgender women in sub-Saharan Africa. And then CAB-LA has great advantages, including high efficacy, but to the point we were making about choice, is efficacy might not be the primary or even or the most important factor that somebody uses to decide what they want to use. And there's discretion. However, there are some cons, which we'll talk about implementation-wise, around how this is implemented and what requirements are indicated for providing this in clinical settings. I also want to highlight this subgroup analysis that Jose mentioned, and that the CAB-LA higher efficacy was really in these subpopulations, which are also the subpopulations that we're seeing the lowest uptake of PrEP, and particularly youth and Black individuals in the US, for whom having additional prevention options might allow us to get closer to our ending the epidemic goals. So really ensuring that this is an equitable choice and that we can roll this out in an equitable way to address some of these disparities that we have unfortunately seen worsening in many populations in the US. So some of the considerations that we think about for implementation of CAB-LA include HIV testing. So HIV antibody testing and viral load testing will present barriers for some from some clinical sites. So being able to do same-day PrEP starts might be more challenging. Doing this viral load testing might require more visits and additional costs, and some clinics just don't have it available. There are also some structures to the visits, including staff and space to do these injections, and being able to do them at a scale that we're able to do for oral PrEP. And in one of the clinics for which I work, the capacity to do injectable PrEP is about 10% of the capacity to do oral PrEP with our current structure. So it's really going to require much more innovation in how we approach this to make this more accessible, provided we have the demand for it. And then how we cover missed or delayed injections, I'm going to talk a little bit about, but you have options for coverage with oral CAB or either TDF-FTC or TAF-FTC, and how you manage PEP in the setting of somebody having a long-acting integrase inhibitor on board also presents some clinical challenges. We also have run into how we access CAB-LA, so off-site pharmacy. I'm going to talk a little bit about buy and bill, the medical versus pharmacy benefit, but how we actually access it is a challenge. Having places to do the injections and restrictions on who can administer injections. We did a lot of innovation with COVID, so it might require some of that with injectable CAB. And then navigating through the myriad of insurance options and coverage for CAB-LA, I think is also going to require more patient support so that they don't get very large bills, because CAB-LA is quite expensive. So it's about $3,700 per dose. So we're talking about $26,000 a year. And there can be both patient or provider upfront costs. So some insurances require buy and bill, where the provider has to purchase the medication and then subsequently bill. There is coverage in many of the public health systems, including Medicaid, but that can vary by state. And there are some assistance programs, which are, like you can see here. There are select pharmacies, so it's not that you can just send the prescription to any pharmacy. There's select pharmacies that are in the specialty pharmacy, some of which might look familiar and some of which might not on this list. And so hopefully this will expand. We want to make sure that there's access and more equitable access. And there is a savings program, and we anticipate that many of the PrEP app programs, like one we have in California, will follow the ADAP for inclusion of a long-acting CAB-LA for HIV prevention. You heard a little bit about the breakthrough infections, and these are some data that Sue Eshelman presented at CROI this year. And so how you manage ART in absence of resistance data if you have a very low viral load and can't do a genotype, and potential to archive, but a management of discord and HIV test results. And then how do we manage discontinuation and tail coverage? If somebody has difficulty with taking oral regimens, then the expectation for them to take an oral regimen to cover the tail for a year is also something that we need to really think about proactively. So when we anticipate there will be missed visits, and we've seen, lots of delays in visits in our 083 study. These are the FDA label about how to cover missed visits, and in my opinion, this is actually quite more complicated than is necessary. So this is stratified by planned and unplanned missed visits, and after 7 days, bridging with CAB, oral CAB, if it's a planned visit, and then alternative to daily oral PrEP if it's more than 2 months, and then if it's unplanned, making this reassessment of resumption. And then if there's a missed visit more than 4 weeks, then reloading with CAB-LA. So this is an alternative approach that I think is how we're implementing this. So we sort of view the flexibility for patients in having 4 weeks around their injection. So if it's less than 4 weeks, counsel the patient to offer oral TDF-FTC and administer CAB as soon as possible. And if it's greater than 4 weeks, then it's a missed visit and they need to be reloaded and supported with TDF-FTC to cover those gaps. And stopping PrEP is because of the long tail. So this is the patient who is entered treatment and is broken up with the partner, has planned abstinence and wants to discontinue PrEP. So how would you counsel him on discontinuing PrEP with CAB-LA? And the way that we approach it is really talk about the tail. And so for individuals who are assigned male sex at birth, the median duration is 10 months, but I also point out that the interquartile range is 15 and the range is 35. So this can be in the system for quite a while, and it's even longer for individuals born female. So really highlighting that this can exist in the body for a very long time, and that and that with declining levels, there will not be the same level of protection, that we want to encourage and support people to use the protection, HIV prevention options that work for them, and then offering them oral TAF or FTDF after their last injection, offering them PrEP, and then remembering that the CDC guidelines actually recommend quarterly RNA testing for a year after discontinuation, given the concern about suppression of serologic changes in response to an HIV infection. So it is something that we talk about with our patients before we start, just so that they have a sense of how we're going to manage both the start and eventual stop for individuals who decide it's not worth it for them to continue. And I just want to end here with a discussion of some of the lessons that we learned from oral PrEP, and that I fear we're making the same mistakes with injectable PrEP. So really supporting awareness with patient and provider education, and talking about how you talk about HIV risk, and really taking risk discussion out and talking about the ways that this can support somebody's sexual health. Really not stigmatizing individuals with the language we use, how we talk about it, not sort of focusing this on this is for high-risk individuals who have problems with pills, but really talking about some option for somebody to use. Addressing some of the biases that exist within our healthcare system that include structural racism and its impact on our on access to care and engagement in care. Some of the benefits navigation and provider education around side effects, as well as patient education around side effects. So I think we have a massive opportunity with CAB-LA that presents some new challenges that I think will exist for other long-acting agents. So it's an opportunity to try to figure out what a good approach would be to allow more equitable rollout and hopefully support individuals for whom this is the chosen PrEP option. So I appreciate your time and opportunity to share some of the perspectives, and I'll turn it back over to Jose.
Thank you, Dr. Scott, for this excellent presentation. We have several questions in the chat over the next few minutes, and then we'll have time at the end. I want to start with a theme of questions that are encompassed both in the pre-registered questions and the chat, and they are focused on coverage, insurance coverage, payer source, etc. for our patients. And basically they all go to the theme is, what are the barriers that medication coverage have you experienced through medical insurance, and what are the best practices in your medical setting? Somebody was asking about a patient with Medicare who required a 20% copay, and how this could be a main barrier. And have you been able to provide this for persons who are uninsured or underinsured?
Maybe I can start. So we have actually, it's been easier to access this for our uninsured or publicly insured patients, provided the uninsured patients don't sort of cross the income threshold that doesn't allow them to access it through the ViiV Patient Assistance Program. But the private insurers and Medicare have been difficult for individuals. So what we've seen is that in the public sector, this is already rolling out, and in the private sector, there's a lot of barriers. So I believe July 1st, there's going to be ICD-10 code associated with CAB-LA, and then some of the specialty pharmacies that service HMOs are starting to place this on their formulary, and so we're getting more of a sort of insight into how this is going to roll out more in the private sector. Excellent.
Thank you. And then an additional question that, or series of questions, how long after discontinuation of CAB or a injection with CAB, or after discontinuation, would you recommend to continue the oral PrEP coverage? And do you have any specific wording on how to discuss the tail? And please, Scott or Colleen or Dr. Scarsi, feel free to add.
I'm happy to to give a brief.
Sorry, go ahead.
So what I generally say is, and again, this goes back to like not undermining the efficacy that we have. In 083, there was actually an 8-week window for the injection. So the 4 weeks is sort of what I tell people is that, there's some flexibility when you can get this follow-up shot. So just if you come in 4 weeks, then you'll be covered and you'll have adequate levels of prevention. And then using the TDF-FTC or CAB, if that's what's available for coverage until we can get you back in for your next injection. And then the tail coverage, I generally just say like this medication stays in your body a long time, which allows us not to have you come back frequently for injections. But there's this long period after that 8-week period that it sort of lingers. And that can be for, a year or more. And it's not that it's dangerous, it's just if you were to acquire HIV, we will be concerned about it causing resistance. That's kind of the language that I use with my patients.
Yeah, the only thing I would add, and this is something that we see not infrequently, what Hyman presented in his case is people that decide that they are no longer going to be at risk. They are going to change their behaviors, and so they don't need PrEP anymore. And so you'll oftentimes maybe have a little bit of trouble convincing someone to use oral daily PrEP. And I think in those instances, for people that are eligible for event-driven or on-demand PrEP, we really need to educate a lot about those, as well as post-exposure prophylaxis, because we know best intentions don't always align with reality, with plans for celibacy. And so I think even those folks that don't want to cover their tail with daily oral Truvada, if they are eligible for event-driven or post-exposure prophylaxis, we need to make sure that we're educating about those.
And perhaps also remind our patients that even if they think the risk will be low, they could potentially encounter themselves in a risk, high risk situation down the line. And even though the tail is long, we really don't have much data on how protective it is beyond the dosing period. So
exactly, yeah.
Because with that, the opportunity to restart oral PrEP, yeah. Excellent. I think we will, Dr. Scarsi.
Well, I just wanted to add, I'm not sure if we addressed your question or the question about how quick we can expect effectiveness. And I think that that's an open question that we don't have the answer to yet. We were talking as a panel about this before, and Dr. Kelley pointed out that there wasn't a time limit in the clinical trials, and we still saw very few infections, so that's good. And there was just a recent phase 1 trial that was published in the British Journal of Clinical Pharmacology that looked at time to peak concentrations, and it was within about the first week after the injection, both in plasma and in the rectal and vaginal sites that they measured.
Thank you. I was saving those questions for when you finish talking.
Sorry.
But I think it went along the fact of what is the time to protection, differences between vaginal and rectal exposure, and this is very, very nice explanation on that. And I think we'll know more and more as time goes by. So excellent. Well, I think we'll pass it on to Dr. Scarsi. This concludes this part of the presentation, and we'll keep going. Thank you.
Well, thank you very much. I'll ask the requisite question if you can see my slides. All right,
yes.
Great. Okay, perfect. Well, thanks very much. So I'm going to talk about a couple of different scenarios related to pharmacology and complicated patient management. So first, I'll introduce you to our patient, who's a 27-year-old cisgender female who is currently on long-acting cabotegravir for PrEP. She's in a serodifferent relationship, long-term relationship with a male partner with HIV who reports to be receiving ART and virologically suppressed, but she really wants to kind of have some additional control and prevention and make sure that she is protected from HIV. I've shown you her medication list because I'm a pharmacist, and so that's always what I start to look at. The good news with cabotegravir for PrEP, as compared to probably what we're used to with antiretroviral therapy and starting that, there's far fewer effects of cabotegravir on concomitant medications. So I worry less about cabotegravir impacting her birth control that she's using. Here she's on an etonogestrel subdermal implant. So I don't worry too much about that in combination. I don't worry about it affecting her seizure therapy, et cetera. So very few drug-drug interactions from cabotegravir onto other medications. So she's coming in today for her 4th injection. So that means she's been on therapy for about 6 months. And these are her laboratory results. And while you're talking to her, the only medication she adds or additional information she provides is that she's been given a new prescription for carbamazepine to further her seizure management. So what do we have to think about when we do have drug-drug interaction screening for patients on CAB for PrEP? As I mentioned, I worry less about CAB causing an effect on our co-administered medications, but we still have to think about what the other drugs are doing to cabotegravir. So starting off, if our patients choose to have the oral lead-in period, we still have to think about all of the absorption-related interactions. And for cabotegravir, just like all of the integrase strand transfer inhibitors, we think about the chelation that can occur with any polyvalent cation. So that's any calcium, aluminum, which you can see both in supplements as well as antacids. So when we're looking at that for the oral lead-in period, we still have to think about how to manage that interaction, which is probably one of the most common questions I get as a pharmacist. And fortunately, we have guidance to give patients, and that's to administer the antacid or supplement 2 hours before or 4 hours after you give the oral cabotegravir. So the good news is that's only a period of consideration during the first month of oral lead-in therapy. And once you transition to the injectable, you eliminate any of the absorption-related drug interactions that we normally think about with INSTIs. So on the other hand, we have to think about metabolism or elimination interactions, both for oral and injectable cabotegravir. And that's mediated primarily through glucuronidation via the UGT1A1 pathway. And that's something that we have to think about with both oral as well as the injectable or long-acting cabotegravir. So one thing I think Jose may have mentioned is CAB-LA has a flip-flop pharmacokinetics. And basically the way that you can think about that is for an oral medication, the half-life or how quickly the drug is eliminated from the body is determined by the elimination rate constant. So how quickly is it being eliminated? In flip-flop kinetics, such as for CAB-LA, the absorption of the drug from that depot site is really what determines the half-life of the medication. So here I've shown you the phase 2 PK data from the HBTN phase 2 trial. In males are indicated in blue and females are in red. And as Jose mentioned, the absorption for females was slower. So you'll see that over time, it takes longer for them to get to the same concentrations as men. But then as you get out to these later time points, they also have slower elimination because that slower absorption is what's determining the half-life of the medication. So it hangs around much longer in females than in male participants. So we can be informed by oral drug interaction studies. So for example, in an oral drug interaction study with cabotegravir and rifampin, or something like that, you would see a similar peak, but you'd see a much faster elimination of the oral product so that the slope of the curve changes over time. And vice versa, if you had an inhibition, you'd see the slope of the curve change as well. On the other hand, with a long-acting product, if you have an inducer or an inhibitor that's changing its elimination, basically the curve just either shifts up or it shifts down. So we don't see that change in the slope. It's more of a shift either up or down in exposure. And so we use that to inform what we know about how to manage drug interactions based on metabolism or glucuronidation for cabotegravir. So here's a clinical PK study, drug interaction, classic healthy volunteer study with cabotegravir orally alone or cabotegravir plus rifampicin, a known potent inducer of UGT. And you'll see in the purple here, you see a significant decline in the in the curve much faster than you see with cabotegravir alone. And that information was then used in physiologically based PK modeling to simulate what we would expect to happen with cabotegravir LA in combination with rifampin, which resulted in the contraindication in the label of using rifampicin in combination with CAB-LA or oral CAB. So back to our case, we have a new prescription for carbamazepine since the patient's last CAB-LA injection. I can tell you carbamazepine is expected to be a potent UGT inducer. So we don't have any clinical data to guide the decision. It was not studied, to my knowledge, as yet with either oral or LA cabotegravir. But the product label does address both carbamazepine and other anticonvulsants that are known to be inducers of metabolism. And it is listed as a contraindicated product with both oral CAB and CAB-LA using that data that I showed you with rifampin, because it's expected that the cabotegravir exposure will be decreased significantly enough that prevention may be impacted. So with that, we come to our question for you all. So how would you manage this interaction today? Would you consider giving the CAB-LA at the same dose, but just more frequently? So every 4 weeks instead of every 8 weeks during the carbamazepine treatment? Would you give a higher dose of CAB-LA, but at the same interval to try to overcome that interaction? Or would you consider switching to either an oral product with TDF FTC or TAF FTC? Okay, great. So it looks like most of you would transition the patient to oral PrEP, predominantly with TDF FTC. Another kind of equal parts would give the injection more frequently or transition to TAF, and then some would give a higher dose. So maybe I'll ask Dr. Scott, what would you do in this situation?
I'd probably agree with the majority around switching to an oral regimen at this point, given that we're already in the data-free zone, and giving a higher dose every 8 weeks is also not been studied, and it's not been studied every 4 weeks for prevention. And whether or not it's TDF FTC or TAF FTC, I think would be up to the patient.
Yeah, so I think that is the safe option, right? I guess I didn't give you the option of calling the neurologist and finding out why they were using carbamazepine, but it's a drug interaction case, so you have to use it. But you're right. So the safe option would be to switch to TDF FTC, no expected interaction with carbamazepine. I will say, so the TAF FTC presents some challenges because it is a female patient. We don't have, unfortunately, an indication for female patients for TAF FTC. And there is also a drug interaction with TAF and cabotegravir that's through a slightly different mechanism of P-glycoprotein, but it's also contraindicated with carbamazepine. So the two CAB-LA strategies I gave you are both of significant interest. I'll point out that the strategy of giving CAB-LA at the same dose every 4 weeks instead of every 8 is actually indicated in the label for another drug interaction with rifabutin. So rifabutin with oral CAB reduced the exposure only about 25%, whereas that RIF exposure CAB exposure with rifampin was about 50 to 60% lower. So with rifabutin, it does allow for more frequent dosing of the cabotegravir at the standard dose to overcome that interaction. But we just don't have that data with carbamazepine. The other strategy of giving a higher dose, we also, in addition to just logistical challenges, we don't yet have data on how well that would work. So overall, I do think we have an advantage of cabotegravir LA. It has overall fewer interactions because we get rid of those absorption-related drug interactions. And it is an uncommon perpetrator of drug interactions. There is some warning around renal transporter that is inhibited by cabotegravir, both orally and via the LA. But it's really only exercised with caution with OAT1 or OAT3 substrates that have a very narrow therapeutic index, so something like methotrexate. But again, not a very common interaction that we would see. So the good news about that is if you did need to switch to an alternative therapy, you don't have to worry about that drug interaction even during the tail. So with that, I'll move on quickly to our same case a year later. So she ended up staying on her PrEP therapy, still on long-acting cabotegravir, and no other changes to her medications that you're aware of. She comes back for her lab results, and we find out that she has a positive pregnancy test. In talking with her, you find out that this was an intended pregnancy. She asked to have her implant removed at her last OB-GYN visit, but she was not yet aware of the pregnancy at this time. So I just wanted to highlight some of the contrasting language that you see in the product lab labeling for CAB-LA. So it basically talks about insufficient human data to adequately assess. It brings in conversations about the neural tube defects associated with dolutegravir and that it's an associated drug. It talks about that long tail that you mentioned in your presentation, Dr. Scott. And then it ends with basically putting it all back in the clinician's lap to make the decision based on the benefit or risk. We contrast that with the CDC guidance. So the CDC guidance first mentions that TDF-FTC is approved and recommended for pregnant or breastfeeding individuals, but it does allow for CAB-LA initiation or continuation during pregnancy because of the known increased risk of the potential for HIV acquisition during pregnancy compared to the theoretical risk of maternal or infant concerns. So what are the data that we actually have? We have some information from LA ART trials showing no significant concerns, as well as some PK data and a few number of people. And what you can see here is that we don't expect there to be a significant change in the elimination of CAB-LA during pregnancy. So even if you stop CAB-LA at the beginning of a pregnancy, more than likely both the mother and infant are going to continue to be exposed during the duration of her pregnancy because we know how long it's going to hang around, particularly in females. And then we also have some information from HPTN 084, 18 results available so far, and we expect to have more data coming from that trial. But then in the real world, we know that women and people of childbearing potential are going to have long-term exposure, and it just wanted to highlight this excellent viewpoint that was recently published about the problems with excluding pregnant and breastfeeding individuals from PrEP trials, as we have a huge gap in what we know. So how would we manage this patient given her new pregnancy identification? After assuring that she has appropriate prenatal care, would you give the long-acting injectable today and schedule her injection as scheduled? Would you discontinue PrEP overall until she's done with both her pregnancy and breastfeeding? Would you discontinue CAB-LA and start oral PrEP with either TAF or TDF? All right, so most again would stop CAB-LA and transition to TDF-FTC. We have probably second place would be to continue receiving the CAB-LA over 8 weeks or every 8 weeks, and then a few that would discontinue or use TAF. So I think that leads nicely into our discussion. But here's just a few summary slides. Again, I think I've mentioned most of the drug interactions that we have to particularly worry about. And I think I'd like to open up the discussion, turn it over to Jose to talk about kind of the challenges for providers in determining what to do during pregnancy in somebody who is either starting or continuing CAB-LA.
Thank you very much, Dr. Scarsi. And I think that goes good with us. One of the questions presented in the Q&A, how do you counsel patients about the risk? How do you counsel patients who wish to stop therapy and then become pregnant? How long would you typically advise for them to wait after one injection of Cabolet prior to a planned conception?
Yeah, well, so I guess first I'll maybe just mention, I'll highlight the PK tail again. I think we heard in the first or second presentation that it could persist up to 76 weeks, but that's just based on the time of follow-up of that study. So in that study, 46% of female participants still had detectable cabotegravir concentrations at 76 weeks. So the actual duration is much longer in a good proportion of our patients. And I think it's going to be hard to ask somebody to wait potentially years to delay a pregnancy or desired pregnancy in that context. I think we can be reassured by the data that we have so far and the animal data. And I think we need to start collecting data and be aware of the antiretroviral pregnancy registry. Even if we do switch someone from CAB to an oral option, they're still really having CAB exposure during their whole pregnancy. I think that data is going to be really important.
Dr. Scott or Dr. Kelley, anything to add?
No, just the last point that Dr. Scarsi made about the CAB exposure really can't be removed, particularly for someone who's had an injection on time and then discovers that they are pregnant. And so, that is a difficult decision to make as far as whether you continue to give additional CAB, but removing the exposure is not really possible. So. But I think the data that we have to date are very reassuring that there is not a high risk to the fetus at this point in time that we're aware of.
And the HPTN is also doing studies looking at this, so hopefully we'll have more data to better inform, because the risk of HIV acquisition, and at least in sub-Saharan African studies, is actually quite high during pregnancy, and so we don't want to lose sight that that there are women seroconverting during their pregnancy if they have ongoing HIV risk acquisition.
And then another question. Thank you for Dr. Scarsi. Pharmacology question. Talked about drug-drug interactions, and I think what drug-drug interaction, we know that long-acting CAB is highly effective to prevent HIV in transgender women who have sex with men. And what do you foresee are the challenges we face in drug-drug interactions in persons who are on hormonal therapy? How do you have any insight on how to address them?
Yeah. So HPTN 084, I believe, does have some data for hormones related to contraception. So they looked at the contraceptives that were used during the study and evaluated kind of in sparse PK to see if there was an effect. And they saw kind of a what I would say maybe is a minor or modest effect of people receiving oral contraceptive pills on the peak concentration of CAB, but probably not expected to be clinically relevant or important. So right now there's no restrictions on providing any contraceptive option in combination with it. I think there's other questions related to gender affirming therapy for trans individuals. And I think we still need additional data in that space to see if there are any effects of either the CAB on the gender affirming regimen or vice versa. I think based on what we know about CAB, we don't expect there to be an effect of CAB on gender affirming therapy. But we did see some unexpected kind of questions around the effect of gender affirming therapy on tenofovir. So I think it's an area that needs to be emphasized in future research.
And it's important to look at this because it could impact adherence to therapy as well as accessibility and uptake.
Absolutely, yeah.
As we have seen in the other video. Excellent. Well, this has been a very lively discussion with a lot of good questions and answers. Thank you to Dr. Scarsi for this great talk. And I will pass it on now to Dr. Kelley, who will talk to about diagnostic dilemmas and treatment.
Okay, thanks everyone. I just have a couple of quick cases that we'll go through that we've seen within the clinical trials for CAB-LA for HIV prevention. So the first case is a 26-year-old cisgender male who has sex with men, who was currently receiving injectable CAB every 8 weeks for pre-exposure prophylaxis, came to clinic for a 6th injection. So this was about 10 months or so of therapy. No other medical problems, adherent to the timely injections. This was a patient who did have the 4-week oral lead-in that, to be clear, is optional now with the FDA guidance. The participant reported 3 condomless partners since the last visit 8 weeks ago, but all prior HIV testing was negative, and there was an episode of rectal GC diagnosed and treated about 4 months ago. So in the clinic, as should be standard of care, rapid HIV test was done and the blood was drawn for the 4th-gen antigen antibody testing. At this point in time, this was during the clinical trial, so we did not have recommendations for viral load testing. STI testing, 3-site testing was also completed, and the injection was delivered based on the rapid HIV test that was done in the clinic. And so we get our lab results back shortly thereafter that showed that the 4th-generation HIV antigen antibody test was positive. The differentiation assay, which in this case was a Genius, the confirmatory antibody test was negative, and the qualitative RNA assay that was done with this commercial laboratory as confirmation was also negative. So positive antigen antibody, but negative RNA assay and negative confirmatory antibody assay. And so the commercial lab interpreted this as HIV infection is unlikely, consider testing for HIV-2 DNA if clinically indicated. The patients then called back to clinic for repeat HIV testing, and at that point in time in the clinic, the rapid test is again negative. The 4th-generation HIV antigen antibody test that was sent to the lab, the same commercial lab, was negative, as well as the qualitative TMA, which was negative. And we also sent at this point in time for an HIV viral load, which takes a bit longer, and so is pending. So I'd like to ask the audience, what would you do next? Would you reassure your patient that this is a false positive and no further follow-up is required? Would you initiate antiretroviral therapy with tenofovir, emtricitabine, darunavir, and cobicistat, a fully suppressive ART regimen? Would you not change therapy and counsel your patient about the possibility of HIV infection and repeat those HIV diagnostics in about 4 weeks? Okay, so the last choice was most popular. Do not change therapy and counsel the patient about the possibility of HIV infection and repeat the diagnostics in 4 weeks. So I'll ask the panel now. Dr. Castillo, do you have any thoughts about this?
Certainly, I think I would probably agree with option number 3. We are facing now multiple challenges that you will discuss about how to diagnose HIV infection in these patients who receive CAB-LA. I would not reassure the patient that this is for sure a false positive, so that I would potentially disagree. But I think you could argue that initiation of antiretroviral therapy could be indicated as well, and perhaps might be the right answer to initiate somebody in the very, very early stages while the rest of the situation is figured out. Truth of the matter is that this will also complicate diagnosis and identification of true HIV infection down the line. And I think these are the dilemmas that we are facing now in the setting of this new prevention era. But so basically, that's a long answer, perhaps for not a clear.
Yeah, no, I mean,
response.
Yeah, I totally agree with you. I think I also favor number 3, but I don't think number 2 is wrong because of the reasons that you just explained. So we will move on. So just to remind everyone, from the clinical trial in cabotegravir, people who were on the cabotegravir arm, 16 total HIV infections occurred. And as was stated previously, 4 of those infections occurred prior to actually getting the CAB. So those were undiagnosed acute HIV at enrollment. And 5 of those infections occurred after long periods of no cabotegravir, so missed injections. And so we would hopefully think that that was due to non-adherence. 3 infections occurred during the oral lead-in period, so also potentially people that were exposed and infected prior to exposure to CAB, or maybe in the early stages when they not quite reached protective levels. But it's those 4 infections that occur with adherence to CAB and expected drug levels that were most concerning, so true breakthrough infections. And we're going to talk a little bit more about that. I will say, though, again, the true breakthrough infections was exceptionally rare in the overall scheme of the study, of the several thousand people enrolled in the study. And so there's still tremendous benefit, even with the risk of breakthrough infection. So this paper by Marzinski et al. From JID of last year actually reviews the seroconversions that occurred in the HPTN 083 trial. And it really is just fascinating. So I encourage you all to take a look at it. These figures in the paper actually very carefully review each of the seroconversions that occurred in the trial. On the x-axis, we have time since enrollment in weeks. And on the y-axis, we have cabotegravir concentrations. The top dotted line is 8 times the PAIC90 of drug. And so well above where someone would be expected to have HIV prevention efficacy. The orange dots indicate the participants' drug levels over the course of time. And what you see here, and the green lines represent the injections, what you see here in blue is the time when the HIV infection was first detected. But because of the conduct of the clinical trial, stored specimens were able to be retested for HIV. And so the study could go back and determine that several weeks in many cases passed between the first episode where the study could detect HIV infection prior to when the first study visit that had occurred was detected by the study staff. And at the top, you can see the results of the antigen antibody test, the qualitative RNA test, the confirmatory antibody test, and the viral load. And you can see how these changed over time for this particular participant. And so one thing to note is that delayed infection was very common in both arms of the study. It occurred, I should not say very common. Delayed infection does occur in people who do seroconvert to HIV positive, but it is not common. Infection in general is unusual and rare in people who are adherent to pre-exposure prophylaxis. But in the CAB arm, all 4 baseline cases and 7 of 12 incident cases did experience delayed detection. And when they went back and tested with viral load testing, they discovered that that would have been detected the infection earlier in almost all of those cases, 9 of the 11. Delayed detection also occurred in the TDF-FTC arm, but it was less common in 3 of the baseline cases and 7 of the 39 incident cases. Again, viral load testing would have detected the majority of them. What's most interesting about these diagnostics is something called assay reversion, in that someone will have a positive test, say an antigen antibody test, that then reverts back to negative at a later time point. This is also true for some of the viral load assays, and you can see that in the pluses and the minuses at the top of the figure, where it will be consistently positive for a while and then revert back to negative before turning positive again. And this is really what can become confusing when we are trying to figure out whether someone has seroconverted to HIV positive. Prolonged viral suppression was also seen in this study, particularly with participants who seroconverted close to the delivery of their CAB-LA injection. Integrase resistance was also detected in 5 cases in the CAB-LA arm, and these are the integrase mutations that were detected, the 138K, the 148K, 140A to S, or 263K. These are common integrase inhibitor mutations that we see with other INSTIs. There was some retained phenotypic sensitivity to the very high barrier to resistance dolutegravir and partial sensitivity to bictegravir in 3 cases where phenotypic data were available. And so while it is rare, INSTI resistance can occur in people with breakthrough infections. And this is an example at the top where the INSTI mutations G140A and Q148R were detected in this participant several weeks after seroconversion due to their CAB exposure. People who seroconvert on TDF-FTC also had resistance detected. About 11 of 40 of those seroconversions had resistance detected. And so when we look at the 084 trial done among cisgender women in sub-Saharan Africa, we see even better results. There were only 4 infections in the CAB LA farm, and they did not find, as was stated previously by Dr. Castillo, that there were no true CAB breakthrough infections, that this participant actually had missed some injections and had some delayed timing. And they also did not detect any major INSTI mutations. So again, even better results with respect to breakthrough and resistance than was seen in the 083 trial in the cisgender women trial in sub-Saharan Africa. So as we said, the drug was FDA approved earlier this year due to its superiority that was seen to daily oral tenofovir emtricitabine. However, we do realize that when HIV seroconversion occurs, it can be difficult to diagnose, and INSTI resistance can occur. So viral load monitoring was added to the CDC guidelines for Q8-week follow-up for people who are getting cabotegravir. As well as to the recommendation actually is for oral TDF FTC. Routine PrEP follow-up guidelines now includes a viral test, either a qualitative or quantitative viral test. This makes me a little nervous because just in my opinion, I think that we could be over-medicalizing PrEP and that it will actually reduce benefits to marginalized populations or people who have trouble with adherence to study visit or to clinic visits. And I hope that this does not reduce our access to people who are most in need of PrEP. So back to our case, that HIV viral load did come back again as non-detectable. And so at this point in time, we favored a false positive, although knowing that assay reversion is possible in people who have had long-acting injectable cabotegravir. We had the participant come back for repeat testing at 4 weeks. Again, it was all negative, including that viral load assay. And so we were leaning more towards a false positive. So we planned for repeat testing in 4 weeks and redose the cabotegravir LA on time with continued viral load monitoring for the short term. And that is exactly what we did. It is important to note in the PrEP guidelines, there is a consultation warm line for people that are having trouble with HIV diagnostics. And I've listed the number here, but it's also available in the CDC guidelines for your use if you ever run into this type of situation and would like to discuss with someone the results of HIV testing. So the next case, I'm going to go very quickly. This is initiating ART after CAB exposure. So again, this is a 38-year-old cis man who has sex with men who is on injectable CAB for HIV PrEP. And this was also in the setting of a clinical trial for about 3 years. At the end of the clinical trial, we did have to transition some people to oral TDF FTC while we are awaiting availability of our open label CAB LA. This participant came for a 12-month follow-up appointment and reported imperfect adherence to daily TDF FTC. Also reported multiple recent new partners and really desperately wanted to be back on IM CAB because of the adherence challenges with the daily pills. Unfortunately, at that point in time, the rapid HIV test was positive as well as the confirmatory tests, and there was a detectable viral load at 30,000 copies. The integrase genotype did not show any resistance mutations, and so that was very reassuring. And the patient was linked to HIV care for an immediate ART start. And so my next question here, what ART regimen do you start? Would you start injectable cabotegravir or rilpivirine? The patient much prefers this because pills are really hard to take. Would you start tenofovir, emtricitabine, bictegravir, tenofovir, emtricitabine, darunavir, Cobi, or would you choose rilpivirine plus darunavir, Cobi? Okay, so the majority of folks chose injectable cabotegravir rilpivirine. And so I'd like to ask the panel, Dr. Scott, what do you think in this situation you would do?
Yeah, I mean, I think that for somebody who has had trouble taking an oral regimen and has seroconverted while was on oral PrEP, you have the option, it looks like from your resistance profile that there's no integrase resistance. So, you know, I think that the injectable CAB rilpivirine, the label says that people need to be virally suppressed before you initiate. So I'd be a little bit concerned given that this is treatment naive and he's got a viral load of 30,000. But, you know, I know that off-label in many clinical settings here, we have been doing that and getting people virally suppressed. And then I would probably favor, if an oral regimen, number 3, I think I would probably favor that. The PI-based regimen seems to have a pretty high barrier in terms of sort of non-adherence, although side effect profiles for patients. So I think that's how I would probably approach it.
All right, thank you very much. So again, we are back to that horrific pharmacokinetic tale that we keep talking about that's been discussed multiple times in the study. So this participant was about 52 weeks after their last cabotegravir injection. And we know from the clinical trial that 23% of people born male still had detectable CAB levels. And so this participant, we might presume, could still be at risk of an infection in the setting of subtherapeutic levels of cabotegravir, where they could develop resistance. And might there even be the potential for archived resistance that we're not detecting on our bulk genotype? And I think it's entirely possible, and we need more to understand about seroconversions that happen in the setting of injectable cabotegravir. This is obviously even more of a concern in people who are born female, where more than 60% had detectable CAB levels at a year after injection. And so just to kind of hammer that point home again, we really need to be concerned about the pharmacokinetic tail based on what we know so far. Maybe it won't be as concerning when more data accrue in the coming years, but for now it is something really to be aware of. And so just to remind everyone, the IAS USA resistance mutation tables are a wealth of information, and where we see lots of cross-reactivity between the resistance mutations that are generated with injectable with cabotegravir compared to the other integrase mutations. It does appear to have a higher barrier to resistance when compared to elvitegravir or raltegravir, but maybe not quite as high a barrier as bictegravir. And so there may be some options that you can choose based on that. But again, on bulk sequencing, our participant did not have any evidence of integrase resistance. And so I think that there's likely pros and there's cons. Our patient really has demonstrated that adherence is challenging because they did seroconvert on oral pills. And we didn't, as Dr. Scott said, detect any integrase resistance mutations on the genotype. The cons in this situation is, could there be archived integrase resistance that we're not detecting? And we're really still learning about resistance to CAB, and especially in the setting of pre-exposure prophylaxis and then on someone who seroconverts. And maybe it's better safe than sorry, just to stay away from it for now. I think I probably side on the same way as Dr. Scott, and really choosing the regimen that the patient is most likely to adhere to with close follow-up. But I think that it could be argued both ways. And so I will stop there and see if Dr. Castillo or Dr. Scarsi has any other comments on that clinical conundrum.
Thanks, Dr. Kelley, for this, highlighting how really we're getting into a new area of diagnosing HIV, and we thought we knew how to do it, and I think we need to relearn it in this new area of prevention. I have a 3-item question that goes along together for you. You mentioned in your talk about qualitative or quantitative tests for monitoring. Also, is there any specific test that that you would that is better recommended? Second, is there any recommendation on a rapid test? One of these, like OraSure, etc., or some other options. And then, how are you getting payment for the frequent monitoring of viral load in PrEP? So it's a long question and a little bit convoluted, but interesting to hear your thoughts, and then we'll open it up for the rest of the panel. Thank you.
Yeah, so I'll try to talk quickly. It was not specified whether a quantitative or qualitative viral load is indicated within the CDC guidelines. I think because either is okay. I think for many people, it's easier to get a quantitative than it is to actually get a qualitative viral load. Not a lot of labs necessarily do the qualitative viral load. So I would get whichever one is easiest and cheapest for you to get. With respect to payment, you're absolutely right that it has been challenging for some places. We are hopeful that the USPSTF guidelines will be updated at some point in time, where they would include viral load monitoring within them, and then that would at least mean that it is covered by our current commercial and public insurance programs. But at this point in time, it's kind of hit or miss as to whether someone is covering the viral load testing. And I think for our public programs, that's especially challenging because these are expensive assays. And I think that is my coming from a state where we haven't expanded Medicaid, and nor do we have PrEP assistance programs for our patients who need them. Payment of these assays is really challenging, and I would not let people, the need for a viral load assay prevent people from giving PrEP to people who need it in that setting, because the risk of HIV seroconversion is just too high. And then the last question, rapid tests. And definitely make sure you're using at least a 3rd generation rapid test, and ideally a 4th generation rapid test, although there has been some issues with sensitivity of the 4th generation rapid tests. I think that is improved most recently, but I don't know if others have a comment on that.
Dr. Scott, any comments on additional comments?
On the rapid tests? Yeah, I think that in many of the clinical settings, I think to Colleen's point about the over medicalization is, we've been able to expand oral PrEP because we've really moved it out of like a lot of clinical settings, and rapid tests are a big part of that and how we do same-day starts. I do shy away from oral fluid rapid test and do a blood-based rapid test. So the Oral Quick has both an oral and a blood-based rapid test. The oral has a very long window, up to like 3 months. So I do think that just has the lowest sensitivity. But the blood-based rapid test, particularly if you can pair it with a viral load test, would give you options to do same-day starts, as well as give somebody their result at the visit. The truth is, the viral load test for injectable PrEP is going to be the more sensitive test. So, if that's able to be drawn, you'll have that result, when it comes back in either a day or a week, whatever the turnaround time is.
Excellent.
But I agree with Colleen. It shouldn't, the absence of viral load testing shouldn't prevent implementation of PrEP options for people that they will use. It works really, really well.
Need them the most. Yeah. Excellent. Thank you. I think we have a few minutes for additional questions for everybody in the panel. And I want to just pose the question to everyone. How do you identify who's the best candidate for long-acting versus oral PrEP? And several questions in the topic. What about the specific subpopulations, for example, persons at risk who use substances, or persons who have multiple mental health comorbidities? And how do you, in your clinic, or envision that you will identify who's the best candidate for long-acting versus oral PrEP? Anybody?
I think for me, it's back to the original conversation, and the most important thing is what the patient desires to take. And so the options are presented, and the patient can choose which one they think will work best for them. And then you go from there.
I would agree. It's what's going to work. What are they going to, what's going to fit into their world and their life the best, and then how can we help them access it, whether that's patient assistance programs or working within their insurance or other programs. I think that's always then the next question is what will work best and what can we get them appropriately.
Yeah, I agree. And then, we use a shared decision-making approach, so really helping the patient identify what values they, prefer. If somebody doesn't like needles, then it's a, much simpler conversation. But, if they have particular values that they are going to use to make their decisions, it'll be really informative to helping to guide them on what options there are. But I do think we also need to be very open about what we can offer. And so I do think it's important to have that conversation. If you can't offer all of those options, either state that out, right? Or offer options for people to go somewhere else to gain it if that's what they want.
Excellent, thank you. A quick question, maybe an answer just from each one of you. Oral lead-in, yes or no? And how to decide when to do it?
Patient preference. I've had some patients that really want to try it out first. before they go to the injectable, and then others that go straight to injection. And I think we can reassure people that straight to injection is safe. There's no additional side effects to be expected. But if they really prefer that oral lead-in, that it is an option for them.
I would agree. Talk about what we know about it and sort of why you would, why you wouldn't, and see what they're most comfortable with.
Yeah, I sort of say that I say the same thing, and we reassure people that it's not a safety concern that you have the oral lead-in, and so I'd agree with the other panelists.
And perhaps in somebody with known adherence challenges, you could discuss that the oral lead-in could potentially enhance those, and perhaps could be a good candidate to, discuss benefit-risk ratio, but at the same time, perhaps encourage the consideration of direct injection. Perhaps I don't know what others think.
I mean, one of the things that I tell my patients as they're coming in for their visits is like, we can give you this injection right after the visit.
Right now,
like you can leave today with the injection, or we can send a prescription. And that actually, for a lot of my patients, it's been a different consideration, because like getting it immediately, not coming back next week for it, is a different calculation, even as long as they feel comfortable with it.
Excellent. We have time for one last question. There's again discussion on how do we consult patients when they are starting CAB-LA, and I think Dr. Scarsi mentioned that the data show the peak is achieved in a week on plasma, but it's complicated, right, Dr. Scarsi?
Yeah, I base that. I put the actual journal article link in one of the Q&A sections, and that is based on when the highest proportion of people in a phase 1 study that looked at lots of different compartments, how many people achieved the highest concentrations across different compartments. And I think a simple answer is a week, but it's certainly much more complicated than that, and I don't know that that necessarily translates to when effectiveness kicks in.
Yeah, I haven't looked carefully at that paper, but peak might be a week, but when is someone 4 times above the PA IC90 in general? What because that's where we think the protective level kind of cutoff probably is, and so that might be even earlier, right?
Yeah, they did look at that. They looked at above, like over 1 time, and then it went over 4 times.
Okay.
But yeah, it's a complicated question, and I don't have a good answer for what do you all tell your patients as far as how long they need to have a second or backup method, or do you do that?
I don't.
Okay.
I tell people we have hard outcomes from these clinical trials that show, significant reductions in comparison to a very good PrEP option. And so, I think that those times of protection are helpful if we have a gap. I actually don't see a gap. This works extremely well. And we saw infections in people who were on the oral lead-in. So that's how I counsel my patients.
And exactly, the oral lead-in could potentially something to discuss when deciding the oral lead-in. Mm-hmm. Well, this concludes, I think, our session for our moderator, Jose, Francisco, or Donna. I don't know if there's any additional discussions that need to be
Yes, thank you, Dr. Castillo. As a reminder to our audience, evaluations and how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's live broadcast.
Excellent.
Here are a list of our upcoming webinars. Our next webinar will be scheduled on Tuesday, July 19th, and that will cover issues in people with HIV and hepatitis B and D co-infections. Here are a list of upcoming courses that we have to register. Please visit the IAS USA website. And here is a dialogue that we have coming up for July 7th that will discuss COVID-19. And registration is currently open for the Ryan White Clinical Conference. Lastly, save the date for CROI 2023, which will be on February 19th through the 22nd in Seattle, Washington. Thank you, everyone. And this concludes today's webinar.
Bye, everyone. Thank you.
Thank you.
Thank you.
Is it just us or are we still live?
We are still currently live, Dr. Castillo.